Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI oncology tumor board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. So this case is a 53-year-old female with a stage 1B2 cervical cancer, diagnosed initially in 2005, now diagnosed in 2017, with a T4N0M0 invasive moderately differentiated adenocarcinoma of the rectum that was found to be KRAS wild type and MS stable. The patient was treated with neoadjuvant chemotherapy followed by surgery, then was noted to have biopsy proven recurrence 13 months later with a hypermetabolic mass in the presacral area. She did undergo additional adjuvant treatment with a good response, but then was lost to follow-up and then presented 30 months later with a PET scan showing multiple areas in the presacral space in the periaortic lymph nodes, as well as a right upper lobe nodule. So first question is, would you rebiopsy this patient to prove recurrent disease? And then also, what systemic therapy would you offer? And would this patient ever be a surgical or radiation candidate? So going through the full presentation, the patient presented with progressive rectal pain, weight loss, and constipation. Decent performance status at that time of 0. The patient did have a history of type 2 diabetes, but no tobacco or drug use, and so was a social drinker. There was no family history of cancer. As far as the cervical cancer history, the patient was diagnosed in July of 2003 and underwent a radical hysterectomy followed by chemotherapy and radiation for essentially curative intent. But then in April 2017, so 14 years later, the patient had the CT4N0M0 colorectal cancer in basically moderately differentiated adenocarcinoma of the rectum identified and treated with 5-FU oxaliplatin for 6 cycles. There was no radiation given because of the concern of retreating with radiation therapy. The patient then underwent an abdominal peritoneal resection with vertical rectus abdominal myocutaneous flap, and no adjuvant therapy was given. There was a surveillance PET CT scan in May of 2018, so about 8 to 12 months later, showing a 3.2 centimeter mass in the presacral area, biopsy proven at that time to be a rectal adenocarcinoma recurrent. In July of 2018, the patient was started on 5-FU irinotecan and cetuximab, had a good response clinically and on imaging, but unfortunately was subsequently lost to follow-up, and about 2.5 years later, re-presented, this time with a PET CT showing extensive disease in the presacral space in the surgical bed, coursing along the right pelvic sidewall, involving the vaginal cuff, and inseparable from the posterior urinary bladder with multiple small bowel loops as well. There were also multiple hypermetabolic periaortic lymph nodes compatible with lymph node metastases and a right upper lung nodule that was concerning as well. Before I move on real quick, Dr. Patel, I wanted to ask you a question. What do you think about the interval between these two cancers? How likely is it that the rectal cancer was a radiation-induced rectal cancer? And does the panel feel that this might change the biology and or prognosis?
These are challenging. It's impossible really to know for sure. But once we get beyond 10 years from a first exposure to radiation, the possibility of a radiation-induced malignancy, I think, is definitely a consideration. So in this case, I suspect that the rectal cancer sort of may have been related to the prior radiation for the cervical cancer, which would have included most of the pelvis.
Yeah, it's definitely been my experience that these radiation-induced cancers, although many times they're sarcomas, but many of them are very, very aggressive and very, very difficult to treat. Dr. Weinberg, have you had the same experience with any radiation-induced secondary radiation-induced cancers?
Yeah, I agree with both you and Dr. Patel. I feel that after a certain number of years, we do feel it's more likely, and they have tended to be a little more aggressive biology, which makes it a little more challenging for all of us, of course, especially because it tends to be aggressive local disease, which we would ideally like to offer local control. Just like this case, actually, I've seen a number of patients that this reminds me of some of my own patients.
Dr. Weiser, 14 years after radiation therapy, does it make the surgery any more difficult?
Yeah, generally it does, especially cervical cancer. The dose of radiation used is generally quite high. So I think it would be a challenge, but doable. And I agree with the rest of the panel that these tend to be aggressive tumors.
Gotcha. All right, Dr. Siegel, this is the PET CT scan from January 2021. There's actually 2 slides if you want me to advance.
Sure, let me talk about this one first, and then we'll move on to the next one. These are a fused FDG PET CT images, and we can see that there's a very avid presacral mass, and that there's a lot of FDG avidity here anterior to the mass. And at this point, we're just supple to the vaginal cup. And if you go one slide forward, here we are down a little lower, and it looks a little strange here. This is just the myocutaneous flap, and we can see around it and almost surrounding it is this extensive FDG avidity. This is just the urinary bladder, but all this is tumor.
Unfortunately, we've all seen patients like this, and this pelvic recurrence can be really, really devastating, and actually often very, very symptomatic as well. So one of the questions came up about rebiopsying the patient, but I think that was more in the context of would this patient need to have additional molecular testing done? Dr. Weinberg, what's your opinion on repeat biopsying from a primary tumor that's maybe 3 years old to a new metastatic or local recurrence? Do you feel like the genetic profile changes enough that it justifies repeating a biopsy and an NGS testing?
It really depends on the context. I find that's an individual scenario. I mean, I think in this patient, if we had in the last couple of years a very sophisticated molecular testing done, I'm not sure it warrants it. It certainly sounds like the type of patient who's got very aggressive biology. And I find it pretty low yield, generally speaking, if it's within a 1 to 2 year radius. I'm not saying you can't do it. We know that there are changes that go on in these tumors, but for those changes to result in clinically actionable manifestations within a short time frame is actually pretty rare. We're all doing these studies now and collecting the data. If a biopsy can be done quick and easy, and it's hard to say no sometimes, but I practically speaking, I don't find it has much implication. We are doing other studies, right? ctDNA and things of this nature that are giving us some interesting molecular information. But I think to be real practical in this case, I find it unlikely that it would prove actionable.
Gotcha. Dr. Patel, I don't mean to sound naive, so I'm definitely the one asking this question, but do you think proton therapy would change the ability to give additional radiation here, or is it still just not an option?
Well, actually, for the appropriate candidate, re-irradiation, is possible in some cases, as sort of expressly for the purpose of trying to get that margin clear for maybe re-resection. There are some specific indications where proton therapy could be beneficial. So an isolated recurrence in the presacral space, for example, which is a common place to find this, is an excellent indication for proton therapy, particularly if surgery is not doable. And that's because you can give this, basically a posterior beam of proton, which then doesn't go any further than the tumor. And in that case, you could maybe achieve a radiation dose that's otherwise unachievable. There are a few select circumstances like that where really proton therapy might make a big difference in either just the feasibility of it or the dose you might achieve. But in general, when we consider re-irradiation, it's for candidates, hopefully for re-resection, and then re-irradiation really is done to give us a better chance for a clear margin resection. And in those cases, there's not that much of a difference. It certainly depends on the dose and where the radiation was given previously. In this case, an APR was done to know, which of the tissues that are remaining have been irradiated or haven't, and how much small bowel is in the field. So there's it's very individualized. So it's hard to say, but in this case, I'd say periaortic lymph nodes or anything that's getting too far up out of the pelvis or the upper pelvis becomes increasingly difficult to re-irradiate.
Dr. Weiser, Dr. Patel mentioned about trying to get these patients surgically resectable, and I'm just sliding back a couple slides here. What kind of response, what degree of response do you think you'd need to see in this patient to offer a salvage surgery, which would presumably be a pelvic exenteration?
Yeah, exactly. It would be a pelvic exenteration. I think MRI is extremely helpful here. We would like to see a response. The idea that this is sort of shrinking gives us, encouragement to go in and spend a day trying to get this out. There's multiple at-risk margins here. So we would potentially use intraoperative radiotherapy if we could, especially if we had a focused margin that we were most concerned with. Over the years, I've become more radical, and although it doesn't look like the sacrum is involved and we're maybe a little bit high on the left image, sometimes doing a sacrectomy gives you the access to get that better margin. The periaortic lymph nodes, which I assume are out of the field and would be M1 disease, makes this not curable. We will do palliative exenterations, but that is a big operation, a tough operation. But I think I'd like to reiterate what you said before. Pelvic recurrence is a very tough problem to fix. Symptomatically is dire, and the changes in quality of life are dramatic. So sometimes we'll do it to try to help that.
Very good. One last quick question, Dr. Weinberg. The patient really never progressed on FOLFOX or FOLFIRI and cetuximab. So what therapy would you consider now?
I mean, I think that, if we're talking about palliation here, although the patient seemed to have a good response to FOLFIRI cetuximab and they clearly hasn't progressed, I might put them back on that, actually, before going back to FOLFOX. I think the peripheral neuropathy for FOLFOX will be an issue if we re-challenge for too long. And if they didn't progress on FOLFIRI cetuximab, I'd sooner do that. If there is, again, a possible role for surgery, that makes a little more sense in that context too, to try to induce a greater response.
All right, thanks. So the panel really recommends that probably no role for rebiopsying this patient unless it was going to be done and critical for next generation sequencing. As far as systemic therapy, using FOLFOX or FOLFIRI cetuximab, more likely the latter just because of the neuropathy, might be the better choice. But it's going to be a long stretch to get to the point to get the patient to a point of actually having a significant response to be able to undergo surgery. Radiation and palliative surgery could be considered because this is a very symptomatic area for these patients to have recurrence.